Good afternoon. Today, we're going to discuss approach to dysphagia. But before we discuss how to evaluate a patient with dysphagia, let us first define what is dysphagia. Dysphagia is a subjective sensation of difficulty or abnormality of swallowing. It is different from odynophagia, which is pain with swallowing, while globus is a non-painful sensation of a lump, tightness, foreign body, or retained food bolus in the pharyngeal or cervical area. Let us now discuss the physiology of swallowing. Normal swallowing consists of three phases: the oral preparatory, pharyngeal, and esophageal. Once swallowing has been initiated, it takes less than 1 second for a bolus to reach the esophagus and an additional 10 to 15 seconds to complete the swallow. This process involves more than 30 muscles, therefore, precise timing and coordination during the oropharyngeal phase are crucial for normal swallowing. In the oral preparatory phase, the bolus is processed by mastication to an appropriate size, shape, and consistency to pass through the pharynx and the esophagus. The oral preparatory phase is under voluntary control and involves the use of cranial nerve 5, the trigeminal, 7, facial, and 12, hypoglossal. The tongue is a critical part of this phase, both for controlling the food so that the proper chewing can occur and for directing the bolus to its proper position for swallowing. After chewing, the bolus is moved to the back of the tongue. The anterior portion of the tongue lifts up to the hard palate and retracts posteriorly, forcing the bolus into the upper pharynx. Elevation of the posterior portion of the tongue by the mylohyoid muscle elevates the soft palate, thereby sealing the nasopharynx and preventing nasal regurgitation. During the pharyngeal phase of swallowing, the bolus is advanced through the pharynx and into the esophagus by pharyngeal peristalsis. This occurs by approximation of the soft palate to the posterior nasopharyngeal wall, which seals off the nasopharyngeal inlet, and by contraction of the superior constrictor muscle. Simultaneously, the larynx and hyoid are pulled upward and forward, allowing the bolus to pass over the larynx without aspiration and causing relaxation of the cricopharyngeus muscle, which makes up much of the upper esophageal sphincter. The pharyngeal phase, unlike the oral phase, is controlled reflexively and is referred to as the swallow response. It involves cranial nerve number 5, the trigeminal, cranial nerve number 9, glossopharyngeal, cranial nerve number 10, the vagus, and cranial nerve number 12, the hypoglossal. During swallowing, respiration is inhibited centrally. In the esophageal phase of swallowing, peristaltic contraction in the body of the esophagus combined with simultaneous relaxation of the lower esophageal sphincter propel the bolus into the stomach. Oropharyngeal dysphagia. The estimated prevalence of dysphagia among community-dwelling individuals who are greater than or equal to 65 years of age ranges from 14 to 33%. In the hospital setting, the prevalence of dysphagia can be as high as 40%. Approximately 70% of nursing home residents exhibit signs of dysphagia, which is often attributable to oropharyngeal dysphagia, while approximately one-third of patients with Parkinson's disease complain of dysphagia. Nearly 80% of these patients have objective evidence of swallowing abnormalities. Oropharyngeal dysphagia can arise from disorder that affects the oral preparatory and or the pharyngeal phase of swallowing. A normal oral preparatory phase requires food to be adequately chewed and presented for swallowing. Proper mastication, adequate salivary production for softening the consistency of the bolus, intact mucosa within the oropharynx, and neuromuscular coordination are all necessary features for the initial phase of swallowing to occur. Several disorders can disrupt normal completion of the oral preparatory phase by the following mechanism. Poor dentation can lead to inadequate mastication of the bolus. A decrease in salivary flow may occur in diseases such as Sjogren's syndrome, following radiation to the head and neck, or from medication that reduce salivary flow, such as anticholinergics, antihistamine, and antihypertensive. Following cerebrovascular accidents, patients may have dysphagia due to reduced lingual control in addition to absent or delayed swallowing reflex and weakened laryngopharyngeal musculature. Patients with Parkinson's disease may complain of oropharyngeal dysphagia during late stages of the disease. Dysphagia results from lingual pumping and a non-propulsive back and forth movement of the tongue that prevents the food bolus from leaving the oral cavity. Disruption of the oropharyngeal mucosa from mucositis, aphthous ulcer, herpetic lesion, or trauma may inhibit normal processing of the bolus. A normal pharyngeal phase requires neuromuscular coordination for propulsion of the bolus, unobstructed lumen, and normal relaxation of the upper esophageal sphincter. During this phase, the larynx elevates and closes at the level of the epiglottis, mainly by closure of the airy epiglottic fold and vocal cords to prevent laryngeal penetration and aspiration. Several structural and functional disorders can result in dysphagia by affecting the pharyngeal phase of swallowing. Neurologic disorder that involves the central nervous system, such as stroke, and motor neuron disease, such as amyotrophic lateral sclerosis, or the peripheral nervous system, such as myasthenia gravis, can cause oropharyngeal dysphagia by disrupting the neuromuscular coordination required during the pharyngeal phase of swallowing. Poor compliance of the upper esophageal sphincter causes incomplete relaxation during swallowing, resulting in dysphagia. Patients with Parkinson's disease frequently have incomplete relaxation of the upper esophageal sphincter and reduce the upper esophageal sphincter opening. In patients with cricopharyngeal bar and hypopharyngeal diverticulum, both functional and structural abnormalities in the pharynx can result in dysphagia. Obstruction within the oropharynx are most commonly due to malignancy. Benign lesion that cause oropharyngeal dysphagia due to obstruction includes cervical rings or webs. Patients with oropharyngeal dysphagia have difficulty transferring food from the mouth to the pharynx and report a feeling of an obstruction in the neck. Patients often point towards the cervical region when asked to identify the site of their symptoms. Other common complaints include coughing, choking, drooling, and regurgitation when swallowing liquid or solid food. Patient may have history of aspiration pneumonia and weight loss. A history of associated symptoms and risk factor for oropharyngeal dysphagia can help determine the underlying etiology. Oropharyngeal dysphagia in an older patient, particularly with a history of alcohol use disorder, smoking, blood in the mouth, or weight loss, should raise concern about a malignant cause. A history of dry mouth or eyes may indicate inadequate salivary production. In such cases, it is particularly important to obtain a detailed review of medication that can reduce salivary flow, a history of radiation therapy to the head and neck, or Sjogren's syndrome. Changes in speech suggest the presence of neuromuscular dysfunction. Hoarseness or a weak cough may represent vocal cord paralysis. Slurred speech may indicate weakness or incoordination of muscles involved in articulation and swallowing. Food regurgitation, halitosis, a sensation of fullness in the neck, or history of pneumonia accompanying dysphagia may be the result of Zenker diverticulum. Pain upon swallowing or odynophagia can result from inflammation, infection, malignancy, or neoplasia. Dysphagia, developing late in a meal, may suggest myasthenia gravis. Oropharyngeal dysphagia is common after intubation, especially in patients with a history of prolonged intubation. The physical examination performed as part of the initial evaluation of all patients with oropharyngeal dysphagia should include examination of the oral cavity, head and neck, and supraclavicular region as they may reveal lymphadenopathy, a mass, facial muscle weakness, poor dentition, or other abnormalities associated with dysphagia. Neurologic examination that includes testing of all cranial nerves, especially those involved in swallowing, sensory component of cranial nerves 5, 9, and 10, and motor components of cranial nerves 5, 7, 10, 11, and 12. The neurologic examination may also detect disorder with more subtle physical findings. Subsequent evaluation depends upon the suspected etiology. In addition to identifying the underlying etiology, the evaluation also serves to assess the severity of oropharyngeal dysfunction and degree of aspiration. For example, for patients with a history of or suspected neuromuscular disease, we perform video fluoroscopy with modified barium swallow and esophageal manometry to permit a detailed analysis of swallowing mechanics and pressures. For patients with no evidence of systemic disease, we begin with fiber optic endoscopic evaluation of swallowing or nasoendoscopy and perform video fluoroscopy with modified barium swallow and manometry if no etiology is found. Here is an algorithm for the evaluation and management of oropharyngeal dysphagia. Distinguishing oropharyngeal from esophageal dysphagia. The first step in evaluating patients with dysphagia is to determine if the symptoms are due to oropharyngeal or esophageal dysphagia. Oropharyngeal or transfer dysphagia is characterized by patients having difficulty initiating a swallow. Patients may point towards the cervical region as the site of their symptoms. Swallowing may be accompanied by nasopharyngeal regurgitation, aspiration, and a sensation of residual food remaining in the pharynx. Oral dysfunction can lead to drooling, food spillage, sialorrhea, piecemeal swallows, and dysarthria. Pharyngeal dysfunction can lead to coughing or choking during food consumption and dysphonia. Patient with esophageal dysphagia, on the other hand, commonly reports difficulty swallowing several seconds after initiating a swallow, a sensation that food and or liquid are being obstructed in their passage from the upper esophagus to the stomach. Patient may point to the suprasternal notch or to an area behind the sternum as the site of obstruction. A critical component of the medical history is determining the type of food that produces symptoms. Is it solid, liquids, or both? Dysphagia to both solids and liquid from the onset of symptom is probably due to a motility disorder of the esophagus, while dysphagia to solids only is usually present when the esophageal lumen is narrowed to 13 mm or less, as seen in strictures. It is also important to ask if the symptoms are intermittent or are gradually progressive. Progressive dysphagia beginning with dysphagia to solid followed by dysphagia to liquids is usually caused by a peptic stricture or obstructing lesions. Intermittent dysphagia may be related to a lower esophageal ring or web. And patients with motility disorder may also exhibit progressive dysphagia, such as seen in achalasia, or may exhibit intermittent or non-progressive dysphagia, as seen in distal esophageal spasm. Associated symptoms or finding can also help to narrow the differential diagnosis. This may include heartburn, weight loss, hematemesis, anemia, regurgitation of food particles, and respiratory symptoms. As an example, chronic heartburn in a patient with dysphagia may be a clue to complication of gastroesophageal reflux disease, such as erosive esophagitis, peptic stricture, or adenocarcinoma of the esophagus. Patients with peptic stricture usually have history of heartburn and regurgitation but no weight loss, while patients with esophageal cancer tend to be older males with significant weight loss. Approach to diagnostic testing. The approach to diagnostic testing to determine etiology of esophageal dysphagia is based upon the medical history. We perform a barium contrast esophagram or barium swallow as the initial test in patients with history or clinical feature of proximal esophageal lesions such as surgery for laryngeal or esophageal cancer, Zenker's diverticulum, or radiation therapy, or patients with known complex or tortuous strictures such as patient with post-caustic injury or radiation therapy. Patients with esophageal dysphagia should be referred for an upper endoscopy to determine the underlying cause, exclude malignancy, and perform therapy if needed. Esophageal manometry should be performed in patients with dysphagia in whom upper endoscopy is unrevealing and or an esophageal motility disorder is suspected. Although certain motility disorder can be strongly suspected based upon their characteristic radiographic appearance when in advanced stages, confirmation with esophageal manometry is required to establish the diagnosis. In this slide is the algorithm on the approach of patients with esophageal dysphagia. This is the end of my lecture. Thank you very much.